Hi, everyone. I am just starting up now. This is Rachel. I'm very excited to be able to meet with you all for my childbirth masterclass. I'm just going to wait a minute. I know that some people are logging on now. So my name is Rachel, like I just mentioned before. I am a maternity nurse. I've worked pretty much postpartum, a little labor and delivery, some in the nursery, the NICU. So I've been doing this class as a way pretty much for people to be more prepared for pregnancy, for childbirth. And it's been a very helpful class so far. I know that we're waiting for a few more people to come up, but this is my childbirth masterclass. Now we're going to go over a few things today. This is an hour class. The first half of the class, we're going to talk about a little bit about pregnancy, but the majority of it will be for labor and delivery, for childbirth, and it's a great way that we all can kind of be interactive with each other. You all can ask questions. I know that resources are kind of limited right now with all of the COVID stuff going on. So at least you can have some resource and somebody that you can ask questions to. So it's really great. So to start off, like I mentioned, my name is Rachel. I have two kids. I have a almost 5-year-old and I also have a almost 3-year-old. I'm from Florida, so I would love to get to know a little bit about you guys as well. You could just say your name, maybe where you're from, and how many weeks you are. It also kind of helps me get an idea of if you're 20 weeks pregnant, the different things to look out for. Most people also, if you're in your first trimester, second trimester, third trimester, it's great just to kind of get an idea of where everybody's at so that we can focus accordingly. So anyways, we have some great stuff to talk about today. Now this PowerPoint, the Childbirth Masterclass PowerPoint, is available also if you signed up for the class. So if you look at the description in this video, you'll actually see the link to sign up for the next class. So if you did not sign up, that's fine. You can still participate in this class. However, if you actually do sign up, you'll be able to get the PowerPoint and you'll be able to get the free digital ebooks as well, which is great. So we have Samantha from Pennsylvania. You're going to be 31 weeks. So congratulations. I know it's so exciting to have a baby. I know that sometimes, especially right now, you're kind of going through a lot of questions in your head, but I hope that we can answer as many as possible. So for pregnancy, and most people that take this class are beyond their first trimester, but usually in the first trimester, as you know, you might get a frequent urination, you might have some morning sickness, and then in your second trimester, you'll start hopefully getting that second wind. You'll start even sometimes getting a little bit bigger. Keep in mind too, with every baby that you have, you might start noticing your changes happening a little sooner. I remember with my first baby, I couldn't really tell that I was pregnant for until maybe like 16 to 20 weeks. You couldn't really tell that I had a belly at all. And then with my second baby, I was like 8 weeks. So I have Annabelle from Florida. I'm from Florida too, by the way. And it was like by 8 weeks, I already was starting to show. I already had a big stomach. I'm like, oh my goodness, I'm 8 weeks and I'm already starting to show. But, of course, with every baby that you have, you'll start feeling the kicks quicker and all of that good stuff. And Alyssa from Illinois, you're 27 weeks. I love how we have people from a variety of different places in your pregnancy journey. So that's fantastic. With me also in my second trimester, I had a lot of nasal congestion. Just make sure if you are pregnant that you're not taking those Afrin nasal sprays, because those can actually cause you to have tachycardia, which is high heart rate. And but the saline drops that they have are good. Second trimester also, you might have frequent UTIs during pregnancy. Some people do have those. Just make sure that you're urinating frequently, that you have good hygiene down there as well. And Braxton Hicks might be pretty common as well. Can anybody tell me, so we have a few people on now, can anybody tell me the difference between Braxton Hicks and real labor? So it's very important for you guys to know, even if you're in the second or the third trimester, to know what is the difference between Braxton Hicks, which are false contractions, versus real labor, real contractions. That's very important for you guys to know, because obviously if you're in the second trimester and you're starting to have early labor signs, you would definitely want to look into that, you know, definitely call your doctor, see what's going on. And they have different things that they can do for that. And Suchi from California is 28 weeks as well. So I'm very excited to meet all of you. So you know, all of you guys are getting up there, definitely. But the difference between Braxton Hicks and real labor, and I will be mentioning this quite a few times during this class because it's important to know, Braxton Hicks are irregular contractions. They can happen 5 minutes and then, you know, 10 minutes and then 15 minutes and then 5 minutes again. They're very irregular and they also go away when you start resting. So with Braxton Hicks are kind of those practice false contractions. You might be sitting down for a little bit, and then at least the Braxton Hicks will go away with some rest and especially with hydration. Real labor, however, real contractions usually don't go away when you start resting. They usually get more intense, and then real contractions are also regular versus the irregular Braxton Hicks. And hi, Shelly from North Carolina. Seems like a lot of you guys are in the high 20s to early 30s, so that's wonderful. You guys have some time to go. And I do have, by the way, in addition to these free classes, if you look on the description for this class, there also is a link for consultations. I have the first consultation is free. So if you guys wanted to sign up, you can also sign up for that as well. I know that it's very difficult to get some good, genuine quality care and prenatal education sometimes. So at least that is a good resource that you guys can have as well. As you start getting to the third trimester, of course, you might have varicose veins. You can always wear those kind of stockings to help with the varicose veins. They have these compression stockings, which you can get on Amazon. You don't have to get the super expensive ones, but Amazon has pretty cheap ones. And then tiredness, of course, you're spending all of this energy for both you as well as your baby. Stretch marks, cocoa butter helps really a lot for that. Shortness of breath is going to happen as the baby's getting bigger, pressing more on the bladder. Of course, you might even have some shortness of breath. And heartburn. Some people say if the baby has a big head of hair that you're more likely to have heartburn. I don't know, both of my kids had a lot of hair and I did not really have that much heartburn, but I guess it really depends on you. And then here's some important milestones for your baby. So yet again, this PowerPoint is available if you sign up for the actual class. So even though you didn't sign up, you can still participate, but if you want the actual PowerPoint, the link is in the description to sign up for the class, just because it has all the downloadable files for you. So some important milestones for your baby. The big one is that at 37 weeks, your baby is considered early term. That is important because anything before 37 weeks, if your baby were to be delivered before then, usually that's a little early. If you went into early labor for that, they might even want to do some infection screenings on the baby, see what's going on. Anything, 37 weeks to 39 is early term. And then at 39 weeks, that's fully term. So let's say you wanted to have a C-section. Let's say you were going in for a repeat C-section. You had a C-section before, you're going in for a scheduled repeat again. Usually it'll be at 39 weeks is the earliest they can schedule you, unless you had some sort of problem. So unless you had a blood pressure issues, they might even schedule you 37 weeks. Or if your blood sugar started going all haywire and out of whack, you might get scheduled before then. But usually it's about 39 weeks. For inductions as well. So if you want it to be induced, they really cannot induce before 39 weeks unless it has a medical necessity, such as the blood pressure was high. Sometimes they might even do it for something called IUGR, which is intrauterine growth restriction. They might end up inducing earlier. But those are the biggest things. So to test your knowledge, we talked about when your baby's considered term. If you were going to have a repeat C-section or in an elective induction, when is the earliest that they can do it? So if there was no other medical necessity, so I'm just asking you guys this question, you guys can put it on the discussion. We will be doing a giveaway in the end of this class for my full childbirth masterclass online, which is a 26-day class that's valued at $50. So I will be giving away that class, which will be perfect for you guys that are in, the high 20s 30 weeks, around there, because that way, by the time you deliver, you would have finished my whole class. But I will be giving the people that have been active and participating in the discussion questions more entries for that giveaway. So 39 weeks is when you are considered fully term, you're ready for birth. That's when you can start getting in for your C-sections and your inductions if needed. And then usually around 18 to 20 weeks, they're going to start doing the anatomy ultrasound when they start seeing the baby's gender, if it's a boy, it's a girl, all that good stuff. And then for your typical prenatal visit schedule, usually around 24 to 28 weeks, they'll do the glucose screen for gestational diabetes. Usually if someone has gestational diabetes, it's well controlled with some diet, maybe some exercise, lifestyle changes. Sometimes you might need treatments of insulin or even long-lasting glucose medications, but for the most part, it is controlled well with diet. The biggest thing with gestational diabetes, however, is when the baby's born, sometimes they might have low blood sugar. Because if you think about it, if you have gestational diabetes and you're continuously giving your baby all of this sugar, the baby, as soon as they're delivered, they're not getting this constant supply of sugar that they've been getting before. So sometimes their blood sugars drop because they're like, whoa, what just happened to all of the blood sugar that I had? So that's one thing that a lot of people don't really realize is that if you're gestational diabetic, sometimes your baby might need to have sugar checks after delivery just to make sure that they're okay. And then we have cervical exams, also GBS cultures around 36 to 40 weeks. GBS is the group beta strep. It is a naturally occurring bacteria that a lot of women have it in the vaginal area. It's just one of the things in the vaginal flora that kind of, it doesn't really do anything for an adult. It's not very, for an adult female, it's not really harmful. However, if a baby were to get it in delivery, it can be devastating and cause a really bad infection. So because of that, if mom is GBS positive, mom will have to have some antibiotics before she delivers the baby. If she delivers the baby without antibiotics, sometimes they might want to check the baby for infection to make sure that the baby does not have that group beta strep in the blood. And then if it does, it's usually a 10-day stay in the NICU so that the baby can have more antibiotics. So that's just to know what to expect, because GBS is actually pretty common also, and it's nothing wrong. It's not something that you can necessarily prevent. It's just something that if you were GBS positive, you would just want to make sure that you have at least those 2 doses of antibiotics. So the biggest thing with that is if let's say your water breaks, you start going into labor, if you're GBS positive, you don't necessarily want to wait as long as you would be able to if you were negative, just because you want to make sure you get those antibiotics in your system. And then typical prenatal exams. So let's say you are pregnant, you are heading in for your delivery. Usually when you come into the hospital, we will ask you for your prenatal records, your prenatal labs. These are the biggest things that we are looking for. So I do work in labor and delivery sometimes, antepartum, but I'm mostly postpartum, which is after you deliver. But when we're asking for your prenatal records, this is what we are looking for. We're looking for your blood work, your CBC, is your complete blood count. We want to see what your iron levels are. If your iron levels are low, there's a possibility we might have to give you iron or blood before you deliver. Usually if let's say your iron level is, I would say 8 or above, usually we don't really do that much before you deliver. If it's below 8, sometimes we might want to give IV iron before, or even make sure that we have it for after. If it's below 7, most hospitals have a protocol where if your hemoglobin, your iron level is below 7, sometimes they do give you blood either before or after you deliver. Most hospitals have that as a protocol. Rubella is also linked to the measles, mumps, and rubella vaccine that most people have every 10 years. But if you are due for your follow-up for that, unfortunately, you cannot have the MMR vaccine during pregnancy because it can be harmful to the baby. So you would have to wait until you deliver if you are due for your rubella. So let's say you're rubella non-immune. It won't really do much for the baby currently. However, you would want to have the MMR vaccine after you deliver, because if you ever get rubella and you're pregnant, it actually can be very harmful to the baby. So that's why we want to see if you're rubella non-immune. After you deliver, you want to have the MMR vaccine. RPR is a syphilis test. We'll test that, and if the RPR does come back positive, because syphilis is a virus, so sometimes you might have had it in the past, and although it might be very, very small and the reactivity is not really that done much, they'll want to make sure that if your RPR status is reactive, we want to see, how reactive are you? Is this an active virus? Is this kind of a passive virus that was an old, or is this a new infection? What is going on? And then if your RPR is reactive, usually the baby will have an RPR test too. And then if that baby comes back reactive, that baby will be in the NICU for some time as well. Hepatitis B is, hepatitis is a virus as well. So if your hepatitis is positive for an old infection, whatever it might have, they might have to have, in addition to the normal hepatitis B vaccine, normally when babies are born, they'll have hepatitis, they'll have a erythromycin for the eyes, they'll also have a vitamin K injection, which prevents blood bleeding in the brain. So the hepatitis B vaccine, in addition to the hepatitis B vaccine, they also have a hepatitis B immunoglobulin, also called the HBIG. So if your hepatitis B status was positive, there's a chance that your baby might have to have the immunoglobulin. Now, one big thing about this is babies are still recommended to have the immunoglobulin if your hepatitis B is unknown. I'm mentioning that because sometimes we have to give babies the extra treatments because we don't have your records. So even though your doctor might be linked to the hospital, try to have a copy of your prenatal records, because in the hospital, anything that's considered unknown, we'll have to treat the baby for, just because we don't know what's going on. So if you come in and we don't have these records, pretty much we're going to have to draw all of them again, and whatever results that we don't have, we'll have to treat the baby for. So let's say hepatitis B, usually that doesn't really come back too quickly. RPR usually comes back quick. HIV comes back quick, CBC comes back quick, but the hepatitis B usually does not. So if we don't have your hepatitis B results and we have to give the baby the HBIG, honestly, it is a very expensive medication that insurances sometimes do cover, but sometimes it's also really expensive. So it is a good kind of practice just to have your records with you so that you don't have to have these extra medications. Plus, you don't want to have your baby doing extra vaccines and extra injections if it can be prevented, of course. GBS also, group beta strep, is a swab. So that's something that they cannot really get the results of that quickly because they'll have to wait for growth and everything. It can take 24 hours or more. So if you have those results with you, it'll be much better. It can prevent treatment, can prevent unnecessary exams as well for you and the baby. So let's say we don't have your GBS status, we'll have to give you antibiotics before you deliver. So that's unnecessary treatments for you. And then if you did not get enough, and then we'll have to do infection screen for the baby, which is unnecessary treatments for baby. So of course, we don't like to do unnecessary treatments. Therefore, I always recommend try to bring your prenatal records with you. That way you can kind of hopefully prevent all of that unnecessary stuff. We have ultrasounds as well. Transvaginals, usually in the first few weeks, they'll want to do transvaginal, especially for your first ultrasound. They'll normally do transvaginal because the baby's too small. After that, they'll be able to do abdominal ultrasounds, which at least is not as invasive. And then a biophysical profile is another type of, it's still an abdominal ultrasound, but it's a little bit more advanced because they're also looking at the baby's heart monitor, they're looking at the fetal heart monitor, they're seeing the reactivity of the baby in addition to the regular ultrasounds. So all of these are just different ways that they're seeing the baby. So for prenatal complications, we talked a little bit about your prenatal visits, we talked about your prenatal exams, we talked about a few things to expect, to bring with you. For prenatal complications, we talked a little bit about gestational diabetes, but the levels are rising a lot. So I figured it would be great to talk to you guys about that. For number one, some symptoms of gestational diabetes, one's thirst, which of course, I mean, you're pregnant, you're gonna be a little thirsty, hunger, fatigue, and of course, high blood sugar. If you have gestational diabetes, you can always try to get a machine. They do have, I'm an Amazon person, so Amazon has them. You can also get, sometimes you can even get your doctor to write you a prescription, and that it can be a medical equipment that some insurances do cover. So that is great if you can have that. Treatments, usually diet, insulin injection, sometimes pills, and complications for gestational diabetes. One is C-section if the sugar is not able to be maintained. High birth weight baby, so the babies sometimes are big from all of that extra sugar coming in. Hypoglycemic baby, which we mentioned before, because the baby was getting all that sugar and all of a sudden is cut off and, you know, boom. And then preterm delivery also sometimes happens just because the baby is, let's say sometimes you have to deliver the baby sooner because of whatever complications from your high blood sugar. So that's gestational diabetes. And then another big one that I want to talk about is preeclampsia. Preeclampsia is high blood pressure, and it can cause seizures. It can cause major complications for both mom and baby. It can even cause something called a placental abruption, where the placenta detaches prematurely from the uterus. So it can cause a whole bunch of complications for both you and the baby. So that's why it's really important to keep up with your follow-up appointments in your doctor, with your OB, try to get your blood sugar maintained. And then if you need to check your blood sugar often, you can always, like I said before, you can go to Amazon, and also some pharmacies even have blood pressure machines that you can actually use for free there. So high blood pressure, some symptoms. And these, by the way, symptoms of high blood pressure usually come after some time. These are kind of late. The thing with high blood pressure is usually you can't really tell. Oh, hi, Jocelyn. You can't really tell that you have high blood pressure usually until your blood pressure is very high. And normally that's up in like the 160s over 110. So if your systolic is that top number, what's really bad at, we'll call it a preeclampsia, is that top number is 160 and the bottom number is 110. Usually we'll say gestational hypertension is normally if that top number is like 140 to 160, we'll say, okay, the blood pressure is getting pretty high. And then preeclampsia and getting very severe is normally that top number is 160. The bottom number is the diastolic number. And then what you'll see is that if your kind of gestational blood pressure, it's just kind of borderline there. It's normally the bottom one's 90 and then up until 110. And then anything 110 and above is considered preeclampsia. So you have the top number and the bottom number. The top number, basically the systolic, is the pressure on the heart when the heart is contracting. And then the diastolic is the pressure on the heart when the heart is relaxing. So what you'll notice is the top number and the bottom number, if they get too high, that's how you can start getting those symptoms and those issues, of course. Treatments for those, early delivery, medication. If it gets too high, so remember how I was mentioning earlier that usually C-sections or inductions will happen about 39 weeks. If your blood pressure gets too high too quickly and it's not really sustained with medications, sometimes they might have to have premature delivery. It can be very early, depending on the severity of your case. I've seen it even in like 24, 26 weeks, unfortunately. It really depends on the case though. And medications, sometimes it's by mouth medications, sometimes it's IV medications. Hopefully it's not the IV ones, but either way, we'll hopefully get it situated so you won't have to have that premature delivery. So we talked a little bit about pregnancy, and I wanted to spend most of the time on labor and delivery. And if we have any questions about anything, you can always let me know. But before we go to labor and delivery, I just wanted to test your knowledge. So we have some people on right now, and I just wanted to test your knowledge about what we just learned in pregnancy. Now, remember, the people that are active in the discussion questions are the ones that will be able to get my free childbirth masterclass access for the giveaway. So my first question, so this is to test your knowledge, guys, of pregnancy before we go into labor and delivery. My first question is, what is gestational diabetes, or what is gestational diabetes? Or you can say symptoms of gestational diabetes. You can say complications of gestational diabetes. How do you know that you have gestational diabetes? But it's very important for you guys to know what it is. And this is the test that they'll normally do for that is the glucose tolerance test. But that's the one that's like kind of a really sugary drink. And you guys can use the discussion on the bottom to answer the questions, by the way. So gestational diabetes, high blood sugar. Exactly, Vicky. Thank you so much for participating in the question. So gestational diabetes is high blood sugar. And one symptom is you're thirsty, obviously, your blood sugar might be high. Some treatments for that is usually diet, medication. Sometimes your babies might have, yeah, exactly, high blood pressure during pregnancy. Thank you, Emily, for responding. Sometimes your babies might be a little bit on the bigger side, and sometimes your babies might have low blood sugar. Keep in mind that with gestational diabetes, just because you have it during pregnancy does not mean that you'll have it after pregnancy. Usually it goes away on its own after you have your baby. And then take a test with some type of solution. And if high blood sugar is detected, you have diabetes while pregnant. Thank you very much, Annabelle. And Crystal said high blood sugar, you're usually thirsty and you have frequent urination. Exactly. So all of you guys were on point there. And then with sugar also, what really helps maintain sugars after delivery, because I'm always thinking about the babies in this case, one thing that really helps is skin to skin. So if you were to have gestational diabetes, try to do skin to skin with your baby because it actually helps to maintain their sugars, maintain their temperature. Babies, when they are cold, this is just kind of a scientific fact about babies. Babies, when they're cold, they do not shiver to make themselves warm like adults. Instead, they metabolize sugar. So a baby that is cold sometimes will be metabolizing all of that sugar that they have and therefore causing hypoglycemia. So if you already have a baby that's at high risk for hypoglycemia because you had gestational diabetes, and then you have a baby that's cold, therefore even dropping that sugar even more, that's how babies can be very severely hypoglycemic and even sometimes have to have an admission to the NICU. So that's why it's kind of a little tidbit I always share with my patients that are gestational diabetic. Make sure that you are doing skin to skin with your baby and making sure that your baby's nice and warm because you don't want that baby to get cold. And then also delaying the bath helps as well, because that vernix that's over the skin, you left the baby with that perfect insulator that really helps to maintain the sugar, maintain the temperature. And if you wipe that all away, it kind of rips that natural insulation off. So just by keeping that vernix on the skin, doing some skin to skin, it helps sugars, help the temperature, and just overall helps with the transition of the baby. And yeah, treatments, insulin, diet, all of that good stuff. So labor and delivery. So most of you guys are heading towards labor and delivery. And if you guys want a private consultation, I have the description on the, in the description, there's a link to sign up for consultations as well. And then of course, I know that everybody's different. So there's no way I can talk about everything that you possibly would ever need to know about having a baby. But at least if we have a personal consultation, I can talk to you specifically about your case and what you need specifically for your family. So it really is helpful. And like I mentioned, at least the first one, we can have a little intro, consultations free. So at least we can talk about you specifically and go over at least some preliminary stuff. And the link to sign up for that is in the description. So sometimes it can be hard to distinguish false labor, Braxton Hicks, from true labor. And then here are some signs that the baby might be coming soon. We have a lightening, which as the baby starts to move down through the birth canal, sometimes you'll feel that like boom, lightning kind of comes all the way from the bottom, comes all the way to the top. You're like, what just happening? That's lightning. You'll have a bloody show also sometimes, and you might even lose your mucus plug. Nesting instinct. I mean, honestly, for me, I think my whole third trimester, I had nesting instinct. Water breaking as well. As your water breaks, by the way, sometimes your water might break earlier in the labor, and sometimes it might actually break later in the labor. Just because you're, let's say, I've heard a lot of people say, oh, I didn't think I was in labor because my water did not break. Your water does not need to break for you to be in active labor. Active labor is basically cervical dilation, like your contractions are causing cervical dilation. That is the biggest difference also between Braxton and Hicks, those practice contractions, and true labor. True labor causes cervical dilation, and it is more regular and intense. Braxton Hicks, however, they do not really cause cervical dilation. They're more irregular and they're not as intense. You can usually walk through them, you can talk through them, and it's normally a little bit easier for you to go through it. And then I do have a hospital bag checklist. Everybody always is asking me, what do I need to bring to the hospital? What do I not need to bring? What are protocols? And right now I do work in the hospital as well. So just a few things you don't need to bring. Most hospitals will provide you. One is diapers and wipes. Most hospital gives you the diapers and wipes. However, if you preferred your own, you can always use those. I mean, I'm not going to say, hey, you have to use ours. It's your baby. You can do what you want with your baby. Abdominal binder and support bands. I normally recommend them if you're having a cesarean birth. It really helps to kind of have a support band around the belly, around the incision site. It kind of just helps to support everything, especially as you're walking. Once you have a baby, one of the biggest complications of after having a baby that a lot of people don't realize is actually blood clots. So if you were to have, let's say, a blood clot in your leg, and then it travels up to your lungs, it can cause something called a pulmonary embolism, which is life-threatening. So that is why we always say, nurses always say, once you have your baby, try to get up. If you had a vaginal delivery, you had a cesarean delivery, whatever have you, try to get up. At least a support band really helps you as you're walking because it helps support your back, it supports your front. And if you had a vaginal delivery, you can still use one as well, but it works very well for cesarean deliveries just because it helps to support your incision site. If you have staples, also sometimes it is a little uncomfortable until those staples are removed. So at least that support band kind of helps you don't feel that kind of pinching that sometimes you'll feel. Pads and underwear is usually supplied by the hospital, although from someone who's actually used the hospital pads, they're sometimes not the best, but they're free. So that's always a good thing that they're free. And then that mesh underwear that everybody loves so much, all the nurses, we always call it the Victoria's Secret underwear. You know, I'm getting a patient out of bed or something. We put on the pads, we put on those big blue chucks, we put on the underwear. I'm like, yeah, this is childbirth. You know, this is childbirth at its best. But you know what? You don't have to look so glamorous. You can look as glamorous as you want, as long as you are comfortable. That is the biggest thing. And then of course you're going to have some bleeding for a while. If your bleeding is heavy, so like, let's say you have, let's say you go to the bathroom, you change your pads, an hour later, you saturate through the whole pad and, you know, you saturated the whole thing again, or even if you have big blood clots coming out like the size of your fist or bigger, those are signs of postpartum hemorrhage. And if that is the case, you'll definitely want to call your nurse, call your doctor. We'll most likely put some Pitocin, which helps to keep that uterus nice and firm. We'll make sure that you're emptying your bladder, because actually if your bladder's full, it can cause more pressure on the uterus, cause it to have more issues with that. Another thing you don't necessarily need to bring is a breast pump for two big reasons. Number one is colostrum is very, very thick, and it does not really come out very well with a breast pump. You would be surprised how many patients I'll get, like they come into their postpartum room, they're like, all right, you know, when am I getting my breast pump? I'm like, well, your baby's with you. The baby's the best pump that you can have. Your breast pump, more than anything, is for babies and moms that have a separation. So let's say you and your baby have a separation, your baby, God forbid, has to go to the NICU, you're not feeling well, you have high blood pressure, you're on magnesium, you'll want to start pumping for stimulation. A breast pump after delivery is not really for production, it's for stimulation. So you would want to, if you have a separation between you and your baby, you would want to start getting pumping at least 1 to 6 hours after delivery or after that separation, because you don't want to lose your milk supply. Your first few days are crucial to build up your milk supply. And if you are planning on breastfeeding, one of the best things you can do is start out as early as possible with a stimulation to the breast, whether it be from your baby or from a breast pump. And then another thing you don't really need to bring are perineal medications. So, of course, after pushing out a little tiny human, you might have some discomfort down there, some irritation, and, that's to be expected, especially if you tear a little bit. I had a first degree with both of mine. Some people are intact, which is wonderful. I know that doctors, they try perineal massage. One good way that you can prevent tearing is just by kind of doing, when you're pushing more with your abdomen than your actual bottom, because what I notice sometimes is if people are pushing when they're really not supposed to be pushing, or they're pushing instead of using their abdomen with all of that muscles, they're using down there instead. That's how sometimes they end up tearing, just because there's just way too much pressure going on down there. And then I am a pro for the perineal massage. And then for the different lacerations, you'll have a first degree is like a little superficial, not that much, all the way up until 3rd and 4th degrees, which go all the way from the vaginal area all the way to the rectum. So those are definitely what you want to avoid. I've actually had some people who opted for cesarean births after having a 4th degree laceration. I cannot even imagine the pain that would be like. But of course, most common I'll see is like a 1st, maybe 2nd degree. And then the type of laceration is also different. Sometimes you might have a vaginal laceration only. Sometimes you might have a periurethral laceration. I find that a periurethral lacerations hurt more when you are peeing, by the way, than a regular vaginal laceration. So not only is it the degree of the laceration that you'll have to, ask your doctor, but also what type of it. Is it periurethral? Is it a vaginal? I find that the just vaginal lacerations are the least painful. Then probably periurethral is a little bit more painful after that, followed by the episiotomies. Episiotomies, they heal quicker than natural lacerations because obviously it's a surgical incision. However, it usually hurts a lot more than tearing naturally. So if a episiotomy was in your plan, just keep that in mind as well. You might have some extra pain after delivery. So in that case, if you were to have that extra pain, I like dermaplast, I like tuck spray. They even have different creams and ointments that you can use. You can also, this is kind of a nursing secret, but those clear plastic bottles that they give you to fill with water, what helps is I find most people, they're nervous about peeing after tearing. So what I do recommend is taking that plastic bottle, filling it with some warm water, and then as you're peeing, actually rinse at the same time. And then the water, that warm water, neutralizes the acidity of the urine, and therefore it kind of helps to prevent that painful perineum after. So that's kind of one thing you can do. They also have those donuts. It's kind of like a cushion. They also have SIDS baths, which is kind of like a little spa that you can sit in. So there's a lot of different things that you can do. And then to bring to the hospital, I wouldn't really worry too much about the things to bring to the hospital. I know that hospital bags are one of the top, I guess you can say, like selling blog posts, and the top thing that people are always trying to think of. What do I need to bring to the hospital? I'm going to make it as simple as possible. You bring to the hospital whatever makes you comfortable. That is pretty much the most basic way I can explain packing your hospital bag, whatever makes you comfortable. I've seen people pack pillows in their hospital bag. I've seen people pack blankets. You can pack a few pairs of clothes for you, a few pairs of clothes for baby, maybe your support person. Keep in mind that right now, you might want to call your hospitals to see what their policies are for visitors. Right now, in most hospitals around me anyway, including the hospital that I work at, we allow one person to stay with mom and baby. However, there's only one person and they cannot leave for the duration of the stay. So that means when mom is packing her stuff, she also has to pack stuff for her support person, whether it be daddy, grandma, sister, whoever it is. It's good to pack for all of you guys if they cannot leave. If your hospital does, I know that some hospitals have a modified restriction where in between the hours of like 2 p.m. and 6 p.m. they can come and go. If they do have that, great, but just keep that in mind. And I would also ask them what their policy is if you were to be positive for COVID. Just because a lot of the majority of the ones that we get in the hospital, and I do take care sometimes of the COVID patients, the majority of them don't even know that they have COVID. Most of them, they're like, what? I was completely asymptomatic. I had no idea. But you would want to know what their policy is if the dad can still stay if mom has COVID. Does mom and baby still stay together if mom is COVID positive? Can mom breastfeed? And of course, all of these things also, if this is just a little tidbit, not only as a nurse, but as a lactation counselor, if the hospital is telling you that you can't breastfeed because of that you have COVID, it is your decision if you would like to or not. That is something that you do have a right to refuse if breastfeeding was in your choice. Sometimes they might want to just keep, be aware that if their policy was against it, you might have to sign a paper like a waiver and possibly have a COVID test for the newborn, either outpatient or in the hospital. But those are things that you would want to talk to your hospital about, because that's not something that every hospital is exactly the same on. So those are just different questions you can ask and you guys can write these questions as well. Another thing too is that even though you might have restrictions for the visitors, pretty much all hospitals do allow people to bring you stuff if your support person or your nurse comes to the front entrance to pick it up. So let's say you forgot your favorite blanket at home, or we need to do a car seat test on the baby. Usually, even though you guys cannot leave to grab those items, you might be able to give your keys to somebody. They can go to the house or to the car, pick it up and bring it back to the hospital. So that is kind of one alternative to help you with that. And I've seen people also, so with the hospital bag, biggest thing, most basic thing, comfort more than anything. And then whatever helps you make your stay as easy as possible. So we have comfort, blankets, pillows, few changes of clothes. Number 2 is also things to make your stay easier. So are you somebody that wanted to sleep train your baby with a noisemaker? Some people have brought noisemakers. Are you somebody who wants to catch up on The Mandalorian? You can bring your Amazon Fire Stick. I've seen some people bring those, or their laptop. I don't know how many of my patients have come in and they've catched up on The Mandalorian or Grey's Anatomy. I guess after having a baby, you want to think about the TV show that you're going to be watching for the duration of your stay. And then, for a few months after that, with my first, it was Grey's Anatomy. With my second, I just watched like everything under the sun. Anyways, so you come into the hospital. Hopefully you'll have your prenatal records that we talked about earlier. If whatever reason they don't have all of them, they might have to redo some of them. Usually when you come into the hospital, they'll do a few exams on you, whether we have your prenatal records or not. Number 1 that they'll always do is a CBC. They'll just want to get a basic. How's your iron levels doing now? How's your white blood cells doing now? If your white blood cells are elevated, it can be a sign of infection. Most hospitals also would have a COVID test. They'll have a rapid COVID test when you enter, or sometimes they might send you to do the COVID test before you come into the hospital. And then another thing they'll do is they'll hook you up to the monitor. They'll see how the baby's contracting. So let's say you come in for for a checkup, you know, are you in labor? You're coming in for a labor check. They'll do your CBC, they'll do your COVID test, they'll do your blood type and screen. They will hook you up to the monitor and see if you are contracting, if they'll see what your heartbeat level is, they'll see what the baby's heart rate is looking like, they'll see if you're contracting, if it's regular, what is going on. They might also do a vaginal exam on you. If you have, here's another nursing thing too that a lot of people don't realize unless they are a nurse. If your waters have already broke, and especially if you have a premature baby, they try not to do vaginal exams as much, just because, of course, every time you do a vaginal exam, it's a higher risk of infection. So let's say your water broke at 26 weeks and you are on bed rest until you do deliver. What you'll find is that they will not be doing vaginal exams as much or as often as if you were coming in active labor. The reason is it's not that they're being negligent or anything like that. It's just they want to try to keep infections at a minimum. And also because sometimes a vaginal exam would actually incite your uterus to start contracting. So I've actually seen it where someone had a premature rupture of membranes, but she was not contracting. And then they did the vaginal exam just to see how everything was doing, to see how her cervix was dilated, because they do have to do that every now and then. And then actually the vaginal exam was what got her into labor, into active labor. And then she ended up delivering prematurely. So that's why studies show they try to minimize it. Although they might have to do it every now and then, they try to minimize it. And then there's different verbiage that you'll be hearing when you go in to the hospital and they will check your cervix. Number one is dilation, is how open is the cervix? Is it wide and open, or is it closed? You're in active labor usually if you're 4 centimeters dilated. And usually that's also when if you wanted to have an epidural, you would want to wait a little bit until at least you're in active labor. I know with my first, I was afraid to have an epidural. So I didn't have it until, well, with my first, I was in labor for like 18 hours and I was afraid to get the epidural. But I wasn't progressing or anything like that. And then I stayed at like 4 centimeters and I wasn't progressing for like 12 hours straight. Every time they checked me, I wasn't progressing. I was just in so much pain. But then I had the epidural and then boom, within 1 hour, I went from 4 to 10. But everybody's different and everybody has different perspectives as well. That was just my experience, is that I was, if you think about it, if you're in pain, everything's constricted, but if you can manage your pain effectively, that's when you can start relaxing. So if you can manage your pain with breathing techniques, you can manage your pain with focal techniques or with labor massages. Those are different ways you can manage your pain. And then that's how you can dilate. But if you just kind of sit there, take all of the pain and not do anything about it, that's when you're going to have some hard time to dilate, because just like anything, when you're in pain, everything closes. Next is ripeness, is softness of the cervix. It needs to be soft in order for dilation to occur. If you're not dilated and you want it to be induced, they might give you a cervical ripener. The biggest thing with that is if they have to give you a cervical ripener, you might have to stay for longer. So there's a difference between an induction and an augmentation. If you're coming in for an induction, they'll normally tell you to come in the night before. So let's say they'll say, okay, come in at 9 p.m. or come in at 7 p.m. You'll know probably that's because they need to ripen your cervix overnight. And then in the morning, that's when you'll probably start getting the Pitocin and start really getting into active labor. That cervical ripener is just to soften it so that when you start doing the contractions, it will actually cause cervical dilation. Because if the cervix is not soft, you might be contracting like crazy, but it's not going to cause cervical dilation. Next is effacement. How thin is the cervix? Is usually a percentage 0 to 100%. So when you're 100% effaced, your cervix is soft and you're 4 centimeters dilated, that's considered active labor. Station is the position of the baby in pluses and minuses. And I mention these because sometimes, we open up our legs for our vaginal exams and you have no clue what they're saying. They're like, all right, the baby's at +2 station, 100%, going fast. She's at 7 centimeters or 10 centimeters. You don't really know what that means. At least now you know what that means. Station is baby's head in plus and minuses, or the baby in general. 0 is engaged in the pelvis and ready for delivery. And that the station, by the way, is judging on the presenting part. So hopefully the presenting part is the head. If the presenting part were to be the foot, like if they do a vaginal exam and then they start tickling the feet, they might say, oh no, we might have to, either try to do a manual to try to manually change the baby's position, or sometimes they might have to do a cesarean birth, depending if they cannot change the position or not. So station and position do go kind of hand in hand with that also. They want to make sure that the baby is coming down. They want to make sure that the position is appropriate for delivery, because if it's not appropriate for delivery, that will definitely be an emergency situation. So position, you want the baby to be head first, and then, it tells you a lot about how your labor and delivery will progress. Also because, sometimes you'll see like sunny side up, or sunny side up is if the baby's coming up with the head up. Sometimes if the head is down, depending on the position of the baby, you might even have more back pain than normal. So it all depends on the positioning of the baby. Then the cervix. Cervix moves from posterior to anterior as you progress through labor. So the closer that you get to labor, you'll see that your cervix will be more anterior as time progresses. So I have another check for you guys, memory check for you guys. So this is going to be a case that I'm going to ask you a question about. So let's say Miss Sarah Lee, I don't know why Sarah Lee, but you guys can answer what you think in the discussion question. Miss Sarah Lee came in for a labor check. She is 4 centimeters dilated. She has a soft cervix that is 75% effaced. The baby is at 0 station and head first. The cervix is anterior. Would you say that Miss Sarah Lee is in active labor? So this is a yes or no question. Isn't Sarah Lee, I think, is a cookie company actually or something, but would you say that she is in active labor? So she's, 4 centimeters dilated, her cervix is soft, it's 75%. Exactly. So we have a bunch of people. Yes, exactly. Vicky, Christy, Shelly, Samantha, all of you guys know, yes, she is in labor, and Miss Sarah Lee will pretty much be soon delivering baby Lee, whether it be a boy or a girl, whatever have you. So we have that. And then we have different stages of labor. We have a few minutes left, so I'll go through this quickly. Number 1, early labor to full dilation is the first stage. Second stage is pushing. So all of a sudden they go, oh, baby's coming out. That's stage 2. After that, we'll have the delivery of the placenta, which of course you'll want to make sure that the placenta is completely out, because if you have placental fragments, that can be at a risk for hemorrhage. And then stage 4 is the golden hour. And this is my other question for you guys. What is recommended to occur in the first hour of life, during that golden hour? What is very, very important to occur within that first hour of life? We did mention a little bit about it before, but after your baby is born, within the first hour, you would want to make sure that you and your baby get to have some time doing what? And I'm sure you guys know this answer too. It's pretty easy question. But the answer is skin to skin and breastfeeding. So very good. We have a few people that knew, yes, skin to skin. Try to do skin to skin and do the first breastfeeding session within the first hour of life. That is the best way that we can get that baby to really start stimulating on mom, getting that milk production flowing, and really getting on a good mindset for both mom and baby. Now, here are some tips for labor, and then we'll do our giveaway announcement and all of that. Number 1 is keep calm. As Stress prolongs your labor, prevents you from dilating. We did mention that your body needs to relax, manage your breathing also. If you think about it, every time you're contracting, you are slightly decreasing the amount of oxygen going to the baby, because as you are contracting, that oxygen flowing to the placenta has a small decrease. So your breathing will help to give that baby a little oxygen boost before that contraction causes that constriction of blood flow. So breathing during labor helps with that. That's also why if the baby's heart rate drops, the first thing that they do, they cut the Pitocin to try to stop those contractions. And they'll put on some oxygen on mom. That's not necessarily for mom as much as baby, to give baby a little extra cushion. Keep your bladder as empty as possible. If you have an epidural, you might need a catheter. And manage your pain. You can always discuss your wishes regarding pain management during labor. If you're in a lot of pain, it'll put more stress on the body. It'll make it difficult to breathe, difficult through to progress through labor. Now, this was the first half of my class, because I do these in hour sessions. If you have not signed up for next week's class, I really highly recommend that you do, because I will be going over postpartum. I will be going over newborn care, starting out with breastfeeding. By the way, this baby right here, do you see how cute that baby is? That's actually my baby Nathan. So that's my littlest one that he's about to turn 3 right now. So he's my little cutie, because he was saying peace right there. But so the second half of this class will be next week. The link to sign up for it is actually in the description. And I wanted to do a quick giveaway also. And remember, all of you guys, if you are pregnant and you want some extra resources, you want somebody to talk to for your questions, as you can see, I love, love, love teaching. I talk about a little of everything. I go over childbirth, I go over pain management. Just wait until I go into the postpartum section, because that is my specialty. I do work sometimes labor and delivery and antepartum, but postpartum newborn care is my specialty. So I have a lot of great tips about that. You can always schedule a consultation. You can email me at mommydidyouknow@gmail.com. You can also contact me anytime. So for our giveaway, on mommydidyouknow.com, you'll see a whole bunch of online classes. If you thought this live class was helpful, my online class is way better. This is like 1 day's worth of material in my 26-day childbirth masterclass, which is available on mommydidyouknow.com. And like I said, it's a $49.99 value, but I will be giving it away to one person for free today. So the way that I will be doing this is I will be doing a little quiz right now, and everybody who participates in the quiz will be eligible for an entry. So I wanted to go over here. So we have a review. So number 1, what are some common prenatal tests to expect? So what are some tests that you will expect to be taken during your prenatal visits or even during the hospital? Some exams that they will be doing. And I'll give you guys a minute. What are some common prenatal tests to expect? And I think this is important too, because when you are a patient, it's not enough. I see a lot of patients, they'll just go, here, take some blood work, and they have no clue what it is for. But it is very important to understand when you are having blood tests, when you are having swabs, to understand what these tests are for and what will happen if any of them were to come off abnormal. So we have Emily and Crystal. They said gestational diabetes, vaginal exams, preeclampsia. So yeah, you will be checking your vital signs often. Make sure you don't have blood pressure issues. Diabetes, STDs, exactly. They'll be checking your hepatitis. They'll be checking your RPR, blood work, CBC, rubella, hepatitis, blood pressure. You guys were phenomenal, right on point there. And then for pregnancy, my question number 4, what are some complications of preeclampsia? So that's my next question, is that 4th bullet point under the pregnancy section. what are some complications of preeclampsia? Now, remember, preeclampsia is high blood pressure. So as someone has high blood pressure, there are some complications for both mom and baby. We did mention a few in my class, but this is important to note because high blood pressure is very silent. Usually you won't really realize that you have high blood pressure until that blood pressure goes really, really sky high. Exactly. But some complications for preeclampsia. So number one, as your blood vessels are getting, yeah, actually very good, Shelly. I didn't even mention that, but yes, you are correct. One complication, and actually I think it was written, but I didn't verbally say it. But yes, Shelly, swelling is one complication of preeclampsia, and that's a sign of preeclampsia. As your blood pressure starts to increase and those blood vessels start to constrict and constrict and constrict, it can cause a stroke, it can cause seizures, it can even cause placental abruptions where the placenta completely comes out prematurely, and that can be life-threatening for both mom and baby. So those are some complications of preeclampsia. Also, small babies, because if you think about it, if your blood vessels are constricting, it's restricting blood flow going to the baby, therefore restricting nutrients going to the baby. So sometimes babies of moms who have preeclampsia also have IUGR, which are intrauterine growth restriction. Then I'll have one more question. Let's see. What is the difference between Braxton Hicks and true labor? So what are some signs of labor? Now this should be pretty easy because I repeat myself often, and I repeated this question quite a few times, but what are some signs of true labor? Some differences between Braxton Hicks versus true labor, true contractions. And that can be anatomy-wise, that can be pain-wise. There's quite a few different ways to tell. Labor is consistent rather than random. It doesn't go away with rest. Braxton Hicks are more irregular contractions. Thank you, Shelly. Thank you, Vicky. You guys were completely correct. Samantha's correct too. Braxton Hicks are irregular contractions. True contractions are regular. Also, a huge thing is true contractions cause cervical dilation. That's a big thing, is that real contractions cause dilation of the cervix. Braxton Hicks do not technically cause you to go into active labor. And then Crystal brought up a good point, is that Braxton Hicks, you can usually talk through, you can usually walk through. Also with Braxton Hicks, they go away as you start to kind of relax. So I wanted to know, I like to know what everyone's favorite part about this class was. So if you had, was there anything exciting that you learned, something that you were like, wow, I never knew that, or I never thought about that? Like, what was your favorite section of this course? That way I know I can focus on it more for, future classes. But I know that I mentioned a lot of little tidbits that you possibly, never heard before or anything like that. But if you thought something was really interesting, you can always share it. And on YouTube, by the way, this channel has a lot of great videos. So I know a lot of you guys are in your second, third trimester. Few of you are in your first. There's videos about a whole bunch of stuff. So you can always subscribe. You can share this video with other people. This is a continuous class that I do also. So if you know anyone that is pregnant, I have a lot of amazing resources for you, for the baby, for your family as well. And you always can follow up with me. I love just, talking to everybody. And on the description, you'll see the link for further prenatal courses. You'll see the link for consultations. So at least you have a lot of support. And there is a link also for reviews. So if you thought that this was very helpful for you, of course, one of the best ways you can help grow this program and support this program also, because I do have a lot of free resources, is by reviewing. If you look on the description, it will be there as well. So Vicky said just how to prep for going to the hospital in general, because I hadn't learned any of that info yet. Yeah, of course. Most people, they talk about childbirth itself. They don't really talk about how to prep before. And then this class was so informative. Thank you. I really enjoyed this section of what's a pack and also all your inside knowledge you shared. So thank you so much. I appreciate that. So we have quite a few people on right now. Oh yeah, first child 21 years ago, of course, new, and of course it's a lot. Even sometimes if it's 2 years difference, it's still a lot of information. So for my giveaway, one person will be winning access to my 26-day childbirth masterclass. I'm thinking of a number 1 through 10. So all of you guys can say, just write in your number that you are thinking of, and then I will announce who thought of the number that I thought of. Everybody seems to love what's a pack. I think a lot of people, they kind of over stress about it, and they're like, I have to bring everything, but it's, generally whatever makes you happy, just like anything else with motherhood. So we have a few people mention their numbers. So anybody to enter into the giveaway, all you have to do is write a number. And then I think that's it for all. So my number was 7. So it is Crystal who won my giveaway. Congratulations. So all you have to do is when you go to the free, I'm not sure if you signed up for the childbirth masterclass yet, the free version, you can sign up for the free version and then send me an email with the email address that you use to sign up for the free version, and then I will manually upgrade you to the full version. So Crystal has won the giveaway for today. Congratulations. Yay. If you want the link for the actual free version too, it is on the description for this class. You'll see on the description, pretty sure it has it down there, but the description has the link for the childbirth masterclass. All you have to do is sign up for the free one, and then I will upgrade you to the full one. So congratulations, Crystal. All you have to do is sign up for the free one. Just email me with the address that you used for your class. And I just wanted to say thank you, everyone. I hope to see you next week when we talk about postpartum care and newborn care. Make sure to share this course with those around you, because I absolutely love to educate and I love to be a resource for everybody. And if you have any questions, you can always let me know. So it was a pleasure, and I hope to see you guys all next week. And you guys are all dismissed. I hope you have a wonderful rest of the day. And I will give you guys another second. You're very welcome, Crystal. And let me know if you have any problems signing up, and I'll be more than happy to help you out. It's mommydidyouknow@gmail.com. And yeah, that's good to know too. Hicks sometimes are not painful. True contractions are painful and consistent. Very good, guys. All right. Have a wonderful rest.